This is the Cardio Ohio podcast, a presentation of the Ohio chapter of the American College of Cardiology. This is Kanny Grewal, president of the Ohio chapter and host for today's discussion. Further information about this podcast, including speaker biographies as well as references, are available at Ohio-ACC.org, where you can also provide feedback and suggestions for future topics. The podcast will also be available for download wherever you access podcasts, and we encourage you to subscribe to receive updates on future sessions. So before we proceed with today's discussion, I do want to add that just 3 days after recording this podcast, the American College of Cardiology, in conjunction with the Heart Failure Society of America, did release the updated 2022 guidelines for management of heart failure. Now, I was able to attend the ACC meeting this past weekend in Washington and attend a few sessions devoted to these new heart failure guidelines. And I'm happy to report that everything we hear from Dr. Castle and Varian is in lockstep with the newest guidelines. Please stay tuned after our discussion for a brief recap of some take-home points from the 2022 guidelines to supplement today's discussion. Welcome to episode 2 of the Cardio Ohio podcast. Thank you for joining us today. Today, we're going to discuss some practical management tips for heart failure. And I'm really happy to have 2 experts from here in Ohio to join in our discussion. First, from Akron, Ohio, I'd like to welcome Dr. Ken Varian. He's a heart failure specialist and clinical cardiologist with SUMA. He's been involved in the Ohio chapter of ACC quite a bit. Ken, thank you for joining us.
Thank you, Kanny. I'm really happy to be here.
And I'd also like to welcome Lindsay Castle. She's a heart failure specialist here in Columbus, Ohio. In fact, she's here at Ohio Health with me, and she's been in practice here for 2 years. Also a heart failure specialist and clinical cardiologist. Lindsay, welcome.
Thank you. I'm looking forward to our discussion today.
So Ken and Lindsay, obviously, all of us are clinical cardiologists, so we all understand the immense burden of heart failure really penetrating every subspecialty of cardiology and every aspect of our practice, whether it's the emergency room, whether it's the inpatient consult service, or whether it's our outpatient clinics. And of course, most heart failure patients are managed by general cardiologists or other cardiac subspecialists. We also have an audience of advanced practice providers today and fellows in training, so quite a broad audience. We know the impact of heart failure is immense, both in resources used, overall cost to our healthcare systems. The first topic I wanted to ask you about is, of course, in the guidelines, most of our providers are very familiar now with several decades of evidence base for the common medications like ACE inhibitors and beta blockers and diuretics. I'm sure you would agree that we often see many patients who are either on suboptimal doses of the guideline recommended medications, or maybe not on all of them for various reasons. Do you have any tips, Ken, for our day-to-day providers on how we can get patients to target doses? And do you have any personal tips on how you titrate the medications or implement them? For example, in a patient who's admitted with new systolic CHF in the hospital.
Yeah, that's one of the things that we focus on heavily every day. So I would start off by saying that for most patients, the goal is to get them on what we refer to now as quadruple therapy, which would be a beta blocker, an RAAS inhibitor, preferably sacubitril valsartan, an MRA, and an SGLT2 inhibitor. The exact order and the speed of titration is very specific to a patient situation. So for example, most of the time I'll start with a beta blocker and one other medication. Beta blocker remains king in terms of its reduction, death, and arrhythmic death, heart failure hospitalization, everything. So we need to get the beta blocker on first usually. I will usually try to get all 4 medications on before I really aggressively titrate, unless I'm dealing with a specific situation such as frequent PVCs or NSVT, then the beta blocker titration will take precedence. Or if I'm dealing with significant hypertension, then the sacubitril valsartan titration may take precedence. If I'm dealing with someone with hypokalemia, the MRA is going to go on very early. If I'm dealing with a patient that has CKD with proteinuria, or maybe has diabetes, the SGLT2 is going to go on first. This is because the SGLT2s are also used to treat those other conditions. The only thing I don't do is I don't add an SGLT2 inhibitor and a renin-angiotensin blocker on the same day. And the reason is that if the creatinine rises significantly, I'm not really sure exactly which one was responsible because both reduce GFR as a part of their mechanism of action. I'm interested to hear if Lindsay has some different methods that she uses in her practice.
Well, thank you, Ken. I actually have a very similar practice to what you just described. So I usually tend to start with very low doses of those four medications and will slowly titrate those medicines after I have at least three, if not four, of the medications started. I think a couple of things I've noticed with my practice is, for instance, if I have a patient with a relatively low blood pressure, I tend to use extended release metoprolol instead of carvedilol. If I have a patient with a very low blood pressure, I might start lisinopril at a very low dose and titrate up to about 10 milligrams before I try to switch to sacubitril valsartan, it sounds like in your clinical practice, you've noticed that that tends to lower blood pressure more than a very low dose of lisinopril, and I've had a very similar clinical experience. Even in my patients that I'm following in the hospital that are very ill in the ICU, even in cardiogenic shock, I've found spironolactone to be relatively blood pressure neutral, and so I tend to add that on very early, again, even in patients that might be presenting with a cardiogenic shock-like state. I do try to titrate very slowly, as I've found that that helps to limit side effects that patients might experience. And I try not to add more than one new medication at a time, as if a patient develops a rash or has a serious side effect, and I've added a couple of medications, it's often difficult to tell exactly what medication caused that rash or serious side effect.
So from both of your answers, it sounds like you would both consider sacubitril valsartan as the optimal form of afterload reduction versus just an ACE or ARB. It sounds like you're both making an active effort to get really every patient with reduced EF on that agent versus one of the older agents. Is that correct, Lindsay?
Yeah, that is correct. My only hesitation has been for patients that have borderline blood pressure and also patients that have severe chronic kidney disease, especially those with a baseline creatinine above 2. I tend to be more hesitant using that drug.
Any other thoughts, Ken?
Well, first of all, I really agree with Lindsay's points, especially with regards to, adding metoprolol succinate when blood pressure is a little bit lower, and the neutral effect of the MRA on blood pressure. I should note that Lindsay and I probably have a little bit of a different definition of low blood pressure compared to internal medicine physicians or maybe even some general cardiologists. We see blood pressures in the high 80s and 90s in asymptomatic patients, and that is considered normal. So we aren't too scared about titrating medications when blood pressure is hanging out around 100 and are fairly aggressive. To answer your question about sacubitril valsartan, I would say that I have the majority, but not a huge majority of my patients on sacubitril valsartan with a reduced EF. And mostly it's just because there are any number of reasons why you would choose a medication like lisinopril or an ARB instead of sacubitril valsartan. One would be hypotension, as Lindsay said. Cost is another issue. And also, it is a twice daily medication. And some of our patients just do better on once daily everything. And you can achieve that. You can achieve quadruple therapy while still doing once a day medications. And that can be important for some patients.
I know some physicians I talk to still have a little bit of skepticism towards that agent only because there was really one main study done and the comparator was enalapril. But it sounds like you're both convinced that at least the evidence base is there, that that's the preferred agent in terms of outcomes and risk reduction.
Yeah, I think that the Paradigm HF trial was fairly definitive. Since then, however, there has been the Paradise MI trial, LIFE, as well as Paragon, which were not nearly as impressive as its Paradigm HF. I do think it is superior. I think that the data is not the strongest. If you use the medication enough, you just get the sense that patients feel better on the medication compared to what they were on before. I don't know how you feel about that, Lynn.
Yes, I would totally agree with your prior statements. And certainly, the majority of patients that I've switched over from an ACE inhibitor or an ARB to sacubitril valsartan feel better. Their dyspnea is improved. They don't seem to have the fluid retention issues that they might have been having before that transition. I notice when I'm following N-terminal pro-BNPs that those are lower. So I would agree with you. Evidence in the medical literature might not be the strongest, but anecdotally, I think all of my heart failure patients are doing better on that drug when I have the blood pressure to use it and the renal function remains stable.
Great, great. I wanted to talk a little bit about diuretics specifically. I mean, obviously, here the goal is really symptom relief and relieving congestion. Most of us are very comfortable in the general cardiology world with IV diuresis, transitioning to oral agents. Of course, we do get a subset of patients that seem resistant to furosemide. Many of us will switch an alternate agent to get a better response. Do you have any tips about which patients may do better with an alternate to furosemide, or when you would consider someone a non-responder and try switching their diuretic agent? Lindsay?
Sure. So that's an excellent question. So usually the maximum dose of furosemide that I would use would be around 80 milligrams BID. Personally, I have not found doses higher than that to be that effective, but certainly the bioavailability for medications like torsemide, for instance, is better than furosemide. So usually after I have a patient on 80 milligrams of furosemide twice a day who is having issues with fluid retention, that is one of the triggers that I see to switch to a more potent diuretic. In my practice, I tend to increase the loop diuretic to the maximum recommended dose, for instance, with torsemide to about 100 milligrams twice a day prior to adding other diuretics such as metolazone. I know in discussion with my heart failure colleagues that some of my colleagues have a lower threshold to use metolazone. So, for instance, if a patient is taking 60 milligrams of torsemide twice a day and maybe calls in with a 5 pound weight gain and some heart failure symptoms, some of my partners, the tendency would be to prescribe that patient either a 2.5 milligram dose of metolazone or maybe a 5 milligram dose of metolazone, and then get a weight or symptom update in 24 to 48 hours. However, my practice has been to actually increase the loop diuretic. So for that same patient who's on torsemide 60 twice a day and has a little bit of weight gain, I probably would go to 80 of torsemide twice a day or even 100 twice a day for 2 to 3 days, and then get a weight update, a symptom update from the patient.
Ken, another situation we sometimes consider on the general cardiology consult services, switching IV dosing of Lasix to a drip. And obviously, I know different clinicians have a different threshold to consider a continuous drip. Is there any advice you have to us general cardiologists about when on the inpatient side we might want to consider a drip, or if ever?
Well, this is an area that, of course, has very little data. We have the dose trial from 2011 that shed some light on this, suggesting that a loop diuretic drip was not better than bolus dosing. I would say that I tend to be a bolus doser once I get up to 80 milligrams of IV Lasix twice a day, and at that point, if I feel like I have to go higher, I will usually put them on a drip of 10 or 20 milligrams per hour. And then I don't usually switch from the drip back to bolus dosing. I usually just turn off the drip and switch them to orals. As you know, heart failure patients tend to come back. And so oftentimes I'll put them on what I know worked in the past. And oftentimes that is a drip. I would say my threshold for a drip is lower, but it's mostly because, days in the hospital equal complication. I know that putting them on a drip can at times speed things up a little bit.
I want to kind of turn our attention a little bit to heart failure with preserved EF as well, since all of us who do inpatient consults know the burden of that condition, especially with the increase in so many of the comorbidities. Ken, is there any new information for us about HFpEF that you can give our general cardiologists in terms of either management advice or any therapies coming down the pipeline?
Sure. So let me start off by giving you what I think the true definition of HFpEF should be. If we're talking about HFpEF, we're talking about truly normal ejection fraction, so greater than 50%. The HFpEF trials, including Paragon, the most recent ones anyway, Paragon HF, as well as Emperor Preserved, these both use ejection fractions of 45% and above or 40% and above, respectively. And so there is a little bit of LV dysfunction patients contaminating these trials. So, for example, in the Paragon trial, there was a hint that there may be benefit for sacubitril valsartan in patients with sort of lower than normal ejection fractions. So the way I interpret that is that sacubitril valsartan is probably somewhat helpful over valsartan in patients with still reduced but mildly reduced EFs, whereas it is not going to be beneficial over valsartan for patients that have truly preserved ejection fractions. That's my take on that data. In terms of new therapies, the biggest news was from last summer when Emperor Preserved was resulted. And what it showed was that there was around a 30% reduction in heart failure hospitalizations in heart failure with preserved ejection fraction patients who got empagliflozin 10 milligrams per day. And this was actually the first positive trial for heart failure with preserved ejection fraction patients for a pharmacotherapy. And there's a couple of footnotes to this. First of all, in every SGLT2 trial, it doesn't matter whether you're looking at diabetics with coronary disease, diabetics with cardiovascular risk factors, chronic kidney disease patients with proteinuria, heart failure with reduced ejection fraction patients. Every patient you give an SGLT2 inhibitor, their risk of heart failure hospitalization will go down by about 30%. So what we found in this trial is that heart failure with preserved EF patients are no different. And there's something about the SGLT2 inhibitor that really gets at the essence of congestion and preventing it. With that said, there's a couple of caveats I would say to the true HFpEF patient when it comes to prescribing an SGLT2 inhibitor. One is that if you look at the Emperor Preserved data, the patients still came into the hospital a very similar number of times between placebo and empagliflozin. There was about 2,500 hospitalizations in each arm, only 500 of which were actually heart failure with heart failure hospitalizations. So while it did reduce heart failure hospitalizations, it did not reduce total hospitalizations. There were also no differences in mortality. So I think that when you go to prescribe an SGLT2 inhibitor for a HFpEF patient, what I usually do is I usually ask myself, the first question is, does this patient's primary problem center around recurrent congestion? That's one. And two, do I have any other reason to prescribe the medication? And most often you do. If they're type 2 diabetic, that's one reason. Do they have chronic kidney disease with proteinuria? That's another great reason to prescribe the medication. And so for that reason, I probably end up putting about maybe a third to a half of my HFpEF patients on an SGLT2 inhibitor, and the other one's not going on because of other reasons. So that's my take on the HFpEF in 2022, but I'm interested to hear what Lindsay's approach is.
Sure. So I certainly agree with your use of SGLT2 inhibitors. When I approach patients with HFpEF, I kind of try to separate them into almost two categories. And so you and I both have certainly seen patients that have HFpEF because of an underlying infiltrative cardiomyopathy. And so when I see these patients, I always want to make sure that something like cardiac amyloid or another infiltrative disease process has not been missed. Occasionally, I will pick up a new case of cardiac amyloid in a patient who's been labeled as having HFpEF for a number of years, unfortunately. However, there's also the HFpEF population that you and I see that unfortunately is really struggling with obesity and poorly controlled hypertension, poorly controlled diabetes, untreated sleep apnea. And I really think that we have to talk to patients about weight loss and exercise and compliance with their treatment for sleep apnea. Certainly, my patients who have been able to lose weight, the patients who are exercising more, have better blood glucose control, those that are using their CPAP at nighttime, I notice anecdotally they do better. They're not the patients that are in the hospital. And really, overall, they tend to feel better. And I think they have an improved quality of life.
Thanks, Lindsay. I think you just encapsulated the entire cardiology consult service the last time I was on service, but that's exactly right. I think we see so much of that comorbidity. And I think what I've noticed is our providers, our APPs, we're much more sensitive about the relationship between blood pressure control, BMI, screening for sleep apnea, which wasn't the case 5 or 10 years ago. So, can I just summarize both your opinions by saying that it's basically time for really every general cardiac provider to get comfortable initiating SGLT2 inhibitors, and that should be part of our armamentarium? And would you both agree that you would consider that a cardiovascular medication at this point in time?
Yes, definitely. It definitely is a cardiovascular medication. I don't think that, every single heart failure patient should be on one for any number of reasons, but it is not a diabetes medication. It is definitely a cardiovascular medication for any number of reasons, based on the fact that our patients prevent worsening of our patients' chronic kidney disease, based on the fact that it helps prevent congestion, and based on the fact that they can reduce the risk of CV death. But to piggyback a little bit on what Lindsay said in HFpEF, comorbidity management is really one of the key things with HFpEF. And even though we are all excited about SGLT2 inhibitors and HFpEF, there just is no pill that can counteract the combination of comorbidities that most of these patients have that you listed: obesity, hypertension, sleep apnea, chronic kidney disease, diabetes. And there's no one pill that's going to reverse the decades of exposure to these comorbidities that often these patients have.
So, Lindsay, you kind of nicely transition into our next topic, which is the role of advanced imaging. You mentioned how there's a subset of patients with HFpEF that you will consider screening for amyloid. So I wanted to just, in our last 10 minutes or so, address that. Obviously, all of our providers were very comfortable using echo as the workhorse of imaging for heart failure. We understand its role for systolic function, diastolic function, assessing valve disease. But there's been a lot of advances in advanced imaging. And as an imaging specialist myself, there's so much literature now supporting cardiac MRI for fine tuning, the etiology of cardiomyopathies, looking for residual scar, looking for active inflammation. And of course, we even have other imaging modalities like pyrophosphate scanning now for amyloid screening that we're doing routinely clinically. So, Lindsay, in your average patient, or typical, I should say, patient who's admitted with, let's start with systolic CHF, reduced EF, when do you think about going beyond the bread and butter imaging of echo to consider either cardiac MRI or a screening for amyloid or other infiltrative disease?
So that's a great question. And I would certainly like to thank you and all of the other imaging cardiologists that are available to help us review these tests that we often order. So my approach has been, as far as ordering advanced imaging, if I'm meeting a patient in the hospital the first time or in the clinic and they have a new diagnosis of acute heart failure with reduced EF, and I don't have a good reason for that. So, for instance, the patient has always had well controlled blood pressure, and we did an ischemic evaluation, and the patient does not have obstructive coronary artery disease. If I'm not seeing something obvious when I first meet the patient, then those are the patients that I do begin thinking about advanced imaging. I certainly order cardiac MRIs to look for infiltrative disease, to look for fibrosis. And so usually a cardiac MRI is one of the first steps, or one of the first advanced imaging studies that I would order in a patient that has an unexplained new acute heart failure with reduced ejection fraction. As far as amyloid imaging is concerned, usually I consider amyloid as a diagnosis in patients that have left ventricular hypertrophy that's not well explained, in patients with other amyloid symptoms, things like paresthesias, in patients that have had spinal stenosis, in patients with history of bilateral carpal tunnel syndrome, or in patients that have had tendon rupture, again, that's otherwise not well explained. Now, most of the algorithms for amyloid testing are actually very easy to find and review. They specifically focus on excluding AL amyloid first. And that is usually done by urine and serum immunofixation as well as a light chain assay. So once AL amyloid has been excluded, then usually I'm at a point where I would order the pyrophosphate imaging for TTR amyloid. Now, sometimes type of amyloid is a little bit more difficult to distinguish. And so I certainly have found cardiac MRI to be very helpful in those patients to look for amyloid infiltration of the myocardium. Other things that make you think of amyloid, of course, would be a significant LVH on an echocardiogram with low voltage on an EKG.
Yeah, I think we definitely, with pyrophosphate scanning kind of coming into the mainstream and being readily available, we've definitely seen an increase. And of course, now with new therapy for amyloid as well, that's pretty exciting that we can intervene on that disease. It's definitely seen a big interest in screening. Is your approach pretty similar, Ken, in terms of when you consider MRI or other advanced imaging?
Yeah, it is pretty similar. I'll get a cardiac MRI on most non-ischemics if they're a little on the younger side, under the age of 60 or so. I do it for a couple of different reasons. If I'm doing it towards the end of their initiation of medical therapy, I do it in part to get a more accurate ejection fraction. So, for example, let's say I get a patient with a garden variety non-ischemic, or at least it appears that way, and I've titrated their medications, and now it's 3 to 6 months later, and I'll get a cardiac MRI to get an accurate ejection fraction, but also to determine the amount of late gadolinium enhancement they have in their myocardium. This can really inform your conversation when it comes to a defibrillator. Let's say the ejection fraction is still 35%, or maybe it's 35% up from 20, but they have no late gadolinium enhancement. You can be pretty confident that patient is on the lower end of risk of sudden cardiac death, and you can give them permission to delay the ICD longer. At least that's been my practice as of late with the recent data on LGE and the risk of sudden cardiac death. Obviously, you're gonna rule out or find the occasional cardiac sarcoid in that mix as well. Or also, you'll also find the patients that are loaded with LGE and you rush to get the ICD, in a few weeks. So it can be helpful in that way. As far as the imaging for amyloid, I don't know if this is what you found too, Lindsay, is that the patients that I'm screening for this, they tend to be a little bit older with some comorbidities, and they almost always have abnormal kappa to lambda ratios. And so it can become a little bit difficult to fully rule out AL in those folks. And so a cardiac MRI or a biopsy is often needed, especially if the PYP is indeterminate. And the second thing I've noticed is that the heart to contralateral lung ratio that we obtain from a PYP scan can be misleading. And so for all of the patients that I order a PYP on, I look closely at the SPECT images to see if there's uptake directly in the heart and not just in the blood pool or other areas, to make sure that I'm dealing with that I'm getting the right diagnosis with the PYP. Because I think the PYP, which used to have very good sensitivity and specificity, I think the specificity is reduced a little bit because of the wider range of patients that we're screening.
Yeah, that's very possible. And we do try to add SPECT imaging now to all our PYPs for that specific reason, to make sure that the uptake is actually cardiac versus rib or chest wall. I want to be sensitive to our time. We've only got about a few minutes left. One very quick topic that I didn't prepare you guys for, but that I just thought of when you mentioned ICDs, is the wearable ICD. And this, I know it's been clinically available for several years. I know there's, skeptics out there from the literature. I know there's supporters. But succinctly, do you think there's a population that does benefit from the wearable ICD on their discharge for initial hospitalization, or do we just need more information to clarify its ultimate role?
Well, I'd appreciate, Kanny, if you can ask me a more controversial question. So I'll tell you what my practice is. I'm kind of an in-between on the wearable ICD. I have colleagues that are absolutely against it based on the negative VEST trial. And I have colleagues that put it on just about everybody with an EF less than 35% that's leaving the hospital and doesn't have an ICD. I offer it to patients who are post-STEMI with an EF less than 35 almost universally, because I do think those patients' risk of sudden cardiac death is high enough. And the only patients that don't go out with a wearable ICD are those that have decided they don't want it. I do not offer the device to anybody that is a little bit older that is a non-ischemic, because I'm not even sure that ICDs are helpful for those patients unless they have a lot of non-sustained VT on their telemetry while they're in the hospital. So it's a little bit of a mixed bag. I do have the conversation a lot, but I also explain to them fully that this is not a proven therapy. I'm interested to hear what Lindsay has to say about that.
So, my practice, Ken, has actually been very similar to yours as well. I tend to worry about the patients who have been in the hospital with a STEMI and have a low EF at the time of that event. And I tend to be a little less concerned with older patients, especially non ischemics, and definitely those with more of a chronic heart failure type syndrome. I think the one thing I've tried to keep in mind with this wearable device is that although we have not shown a strong clinical benefit in the medical literature, there has not been shown any harm for the use of the device. And I usually include that in my discussion with patients as well. And of course, although we try to separate anecdote from the medical literature and from what we're doing on a daily basis, I have had two patients in my a relatively short career to date that have received life-saving shocks from the device. And so that's something that also plays a role in how I decide to use the device.
So it sounds like with the paucity of literature, it's kind of a patient-centered joint discussion that we should be offering our patients regarding the potential benefit and also the downsides. Well, I've thought of a lot more questions, unfortunately, but because of the time crunch, I'm wondering if we may need to have a part two to our heart failure podcast at some point in the future, if both of you would be willing to join us. Is there anything else, Ken, you'd like to add to our general cardiology audience before we finish up in terms of either potential new treatments or maybe advice on when a patient needs to see an advanced heart failure provider?
So great question. So in terms of referral to an advanced heart failure provider, it's individualistic. If you're a cardiologist that doesn't treat a lot of heart failure, for example, if you're an electrophysiologist or you focus only on intervention, then the referral threshold would be lower. For other general cardiologists, it'll be much higher. I would say that any patient who you are down titrating medications because of blood pressure or who are having worsening symptoms that you are unable to control with medical therapy, that is a person that you should be worried is heading towards advanced heart failure. And at that point, the patient should see an advanced heart failure cardiologist pretty quickly because that is a person that may be going on to advanced heart failure therapies.
Lindsay, any other final thoughts?
Sure. I know that our practice in particular sees a lot of patients that are referred after they've had multiple heart failure hospitalizations as well. So even patients with heart failure with preserved ejection fraction, who you're not really thinking, oh, this patient might need a heart transplant or might need an evaluation for a left ventricular assist device. I do think that there's a very important role for the use of heart disease and heart failure management programs in helping to keep patients with heart failure with preserved ejection fraction out of the hospital. And I know that that constitutes a large portion of our practice here at Ohio Health. I would also just like to say that I look forward to continuing to collaborate with general cardiology colleagues and with primary care physicians. I think, again, even in my short career, I feel like I'm seeing more and more heart failure patients every time I'm on the inpatient service. And I think it's really going to take a large group of providers to care for these patients, not just heart failure providers specifically, but certainly as we use SGLT2 inhibitors more, as we titrate diuretics to try to prevent heart failure rehospitalization, and as we also tackle these diseases like obesity and diabetes and hypertension. I think it's going to take a number of both specialists as well as primary care to provide appropriate comprehensive care for these patients.
Well, I think the pearls and advice both of you have given out during this podcast will be a great first step towards accomplishing that, because certainly I've learned a lot myself, and I'm sure our listeners have as well. We will be emphasizing heart failure as well at future Ohio-ACC educational events, given all the new information and new agents coming out. So there'll certainly be more to come for all of our providers. In the meantime, I just want to thank you both for taking so much time today to chat with us about your knowledge and experience. And I definitely look forward to future discussions with both of you. Thank you both.
Thank you. Let's do it again.
Thank you.
So, as I mentioned at the beginning of our podcast, the 2022 heart failure guidelines were released just a few days after we recorded this podcast by the ACC in conjunction with the AHA and the Heart Failure Society of America. I'm happy to report that after attending several sessions devoted to these guidelines and reviewing them myself, that almost everything we heard in today's discussions from Dr. Varian and Castle are completely relevant and, in fact, directly in lockstep with the new guidelines. For example, the guidelines specifically endorse a 4-drug regimen that, as Dr. Varian mentioned, includes sacubitril valsartan or an ACE or ARB as second-line options, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors, exactly as he reviewed. They did clarify some newer or updated definitions of heart failure. As Dr. Varian mentioned, heart failure with reduced EF now is considered 40% or lower. Heart failure with preserved EF is an EF of 50% or higher. And now there's a new category of heart failure with mildly reduced EF between 40 and 50. And then finally, a fourth category is heart failure with improved EF for patients who previously had an EF below 40 and have now improved above that threshold with therapy. So that is one clarification. Finally, as Dr. Castle clarified very eloquently, it's now critical that we do consider amyloidosis in the differential for heart patients with preserved ejection fraction, especially with the classic either echocardiographic or clinical features that she alluded to. This is a big point of emphasis in the new guidelines. And once again, Dr. Castle was right on target with her recommendations for how you proceed with that workup. And then finally, in the guidelines, many other topics are addressed, including the roles of ICD, the need to treat comorbidities, as Dr. Castle outlined, and many other relevant topics. The guidelines are available at the nationalacc.org site, of course, along with all kinds of supporting materials, including summary documents and other educational materials as well. So please check that out. Thank you for joining today's podcast. For more information about the speakers or the topics, please go to Ohio-ACC.org, where you can also provide feedback and suggestions for future topics. The podcast is also available for download wherever you access podcasts, and we encourage you to subscribe to receive updates on future sessions.